I was presenting a case. I was asked to discuss neurologically a case of a patient, a 60-year-old woman, who developed painful neuropathy, not very severe, but obviously painful, and was treated. And within 1 year, myeloma was diagnosed. And the question was, is this related to myeloma? What examination should be done? What needs to be done? And the summary of my appreciation of that case is that this neuropathy appearing about 1 year before the diagnosis could have been a chance, because we know that in patients over 50, 60, we also have neuropathies up to 40%, which we do not know. But however, we know that out of those 40%, maybe 8 to 10% are related to MGUS or to paraproteinemia. Then I explained that that neuropathies have a different profile, whether it's IgM, IgA, or IgG. And this case was an IgA paraproteinemia, so the chance that it was a severe neuropathy coming from myeloma is not big, but it has a certain percentage of neuropathies. And then of course, I explained that it's very important, before you conclude it could be related to the disease, you need to exclude other kinds of neuropathies in that age group, which could be diabetes, which could be previous therapies, not only cancer, but also, like, say, tuberculostatic treatment or anti-rheumatic treatment can cause neuropathies. And once you have excluded that, I recommended, of course, that the patient should be investigated by a neurologist. And I also recommended that also for oncologists it may be useful, if they see their patients often, 3 things would be useful. One would be to have a patient self-evaluation questionnaire, which goes to things like, I have numb fingers, I have pain in the feet, I have trouble walking, and there are such questionnaires, and patients can do that without the help of the doctor and just present the score. The other thing is, for the examination, I recommended the 10-gram filaments. These are little plastic threads, and when you press them on the skin, they bend once you have reached 10 gram. There could be also 20 gram, but 10 gram has been approved for diabetic neuropathy, and they have found that if patients feel these 10 grams on the feet, they have no risk for pressure sores. However, if they don't feel it, you have to be careful. And then I also suggested that a vibration tuning fork would be good to use, also because you can calibrate and then you can compare the disease. Then I was asked to speak about therapy, and for this very case, for the IgA neuropathy and for most axonal forms, there is no specific therapy except symptomatic therapy. And however, there are some types of neuropathies, like the IgM-related MAG type, which is related with IgM paraprotein, and there may be also a chronic inflammatory demyelinating disease that's called CIDP type. These are far worse cases. They need specific treatment like immunoglobulin, plasmapheresis. And to discriminate in the beginning, I suggest also that a nerve conduction should be done, a very simple nerve conduction, just to discriminate whether it's an axonal type or a demyelinating type, which can be good to place the context of the disease. I was also asked by the faculty what my opinion is about nerve biopsy, and I said it's usually not necessary. And it's quite a big thing to do, and if you do it, you need specialists to do it. And it's only valid for if you suspect amyloidosis, because then you need to prove what you're having. And then I moved over to therapy, and symptomatic therapy could be pain therapy, and I was just going through the presently used drugs against neuropathic pain, which are anticonvulsants, some antidepressants, opioids in severe cases, and also increasingly surface therapies like lidocaine patches or capsaicin in more severe cases. And then I also presented a list of drugs that are under investigation and we do not know. And I pointed out that cannabinoids are asked by for every patient. They say, I've seen in the internet, you should. So we don't have a proof of that. At the moment, there is no study to convince me that I should prescribe cannabinoids for pain. And then equally important is, of course, physiotherapy. And I try to point out that physiotherapy is not targeted to gain muscle strength and make patients strong, but to take care of the balance. Because sensory dysfunction usually produces imbalance, and patients have some trouble with gait, or in the worst case, they may fall. And so this physiotherapy should be directed against balance and coordination, if needed. And then I also said if there was trouble with the feet or with the severe sensory symptoms, the shoes should be inspected, and also podiatrists should be involved. And thirdly, what I always tell my patients, if they have some severe or more severe neuropathy, they should adapt their home. Like carpets should not be in the way when they walk to the bathroom, or they should have something to hold on if it's dark, that they don't stumble and fall. And the prevention of falls is one of the most important things, in particular in elderly people. The the paraprotein develops according to the type of malignancy, and some of those cells secrete a monoclonal IgM, which is one protein which is well characterized. Some do IgA and some do IgG, and there are also some light chain variants. So this is really given by nature what kind of paraprotein appears. But for us as neurologists, we know, or we have enough studies saying that in IgM you have a high risk of antibodies involved and a more severe neuropathy. In the others there is, but it's less risky. And that's good to advise our patients and also to advise our partners, the oncologists. I would say, I think we are, as neurologists, we are impressed by the scientific approach and by the many advances that are done in myeloma and in paraproteinemia, and I think we can learn a lot. We also are impressed that some of the drugs have side effects, and that's interesting for us too. So we are in a constant process of learning and seeing what kind of side effects there are and how they work. So never forget to ask us for opinion. And I did not mention this, but I mentioned in my talk. Of course, sensory symptoms in the feet must be always looked at with caution, because it can also be something else. It can be the beginning of a spinal cord compression with myeloma. It can be also some vertebral problem. It can be a different type of neuropathy. So if the patient comes to you and complains of neuropathy symptoms in the beginning, always make sure to ask a neurologist in case of doubt what to do. And finally, I think the credo is that neuro-oncology is a very multidisciplinary and multi-professional work. And we neurologists were happy to participate. And it's so important that we acknowledge each other and work together for the patients.